You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 2nd, 2024. This week, we talk about two downsides of pulse field ablation for AF ablation, a bad surrogate in atrial fibrillation care, and some big controversies in defining future cardiac risk. First topic, the journal JACC-EP has published two mildly sobering studies on pulse field ablation. The first is on autonomic tone. Now, this is from the Advent authors, first author Ed Gerstenfeld, and they set out to compare heart rate and heart rate variability measures after pulse field ablation versus thermal ablation. Now, heart rate variability and heart rate are measures of autonomic tone. Now, recall that the Advent study was the U.S. regulatory trial comparing PFA to thermal ablation. New England Journal of Medicine published it last summer. About 600 patients were randomized to either ablative strategy. There were no differences in the primary endpoint of procedural success, nor any differences in safety outcomes. PFA procedures took longer and used more X-ray time. No matter, PFA is white hot in EP right now. It is the shiny new car that people want. Or in my world, the newest aero bike. The JACC-EP paper included about 2/3 of the patients in each group, PFA or thermal, who completed 6 and 12-month Holter monitors. They found that compared with PFA, patients in the thermal ablation arm had significantly greater increases in heart rate from baseline to 6 and 12 months, and the differences were not that great, were like 10 versus 6 beats per minute on average. Heart rate variability, too, was lower at both 6 and 12 months after thermal ablation compared with PFA. The autonomic effects were similar in both the thermal ablation types, RF or cryoballoon. Think fire and ice. My comments. Now, this may seem a bit in the weeds of AF ablation, so let me explain. The first thing to say is that when we do AF ablation, we're basically doing PVI, pulmonary vein isolation, by freezing or heating left atrial tissue around the ostium of these veins. We create an electrical fence so that PACs from the PVs cannot trigger AFib. Yet we have no idea why this seems to work. Studies that go back and look at durability of PV isolation or that electric fence find that many patients have gaps in the fence and the veins are reconnected. Now, that may increase the odds of AF recurrence, but oodles of patients without AFib have reconnected veins. This imperfect association between total PV isolation and durable PV isolation and AFib recurrence suggests that the PVI lesion set does other things to suppress AF, and one of those other things may be modulating the autonomic innervation of the heart. The GPs, or ganglionic plexi, lie in close proximity to where we ablate to isolate PVs, and many times during PVI, we observe rises in heart rate, and this can persist for days, weeks, or months. So, in general, and of course we don't know for sure, a rise in heart rate and decrease in heart rate variability, which are measures of decreased vagal tone, are considered desirable, especially in younger patients who often have, quote, vagally mediated PAF. So in this Gerstenfeld et al. Study, PFA, likely due to its cardioselectivity, doesn't seem to have this effect on autonomic tone, That may be a reason why PFA has shown zero improvement in ablation efficacy. I find this a compelling theory, especially in younger patients who may have a vagal component to their AF. The lack of benefit of PFA for efficacy is curious because it sure seems like PFA is quite good at ablating atrial myocardium. The post-PFA lesion sets I see in journals and on social media are extensive. Why, I ask, with this ability to vanquish atrial myocardium, does PFA not improve on ablation efficacy? And lack of autonomic effects may be a possible explanation. All right, JACC-EP also published a second PFA study, this one on the matter of hemolysis. My colleague, Dr. Pavel Osmansik, and his team in Prague studied the newly discovered PFA complication of hemolysis, or in colloquial terms, the busting up of red blood cells during the pulse field ablation. They conducted a single-center study of consecutive patients who had either PFA or RFA. Now, this was a non-randomized comparison, but they measured the concentration of RBC microparticles at baseline, immediately post-ablation, and then at 24 hours. To be honest, I've never heard of RBC microparticles, but it's seemingly a good measure of how many RBCs are busted up or hemolyzed during the ablation. They also measured other things that implicate hemolysis, and that is LDH, haptoglobin, and indirect bilirubin. Now, to be sure, this was a small study of only 70 patients, but keep in mind they are measuring a continuous endpoint of RBC microparticles. They're not measuring a binary outcome like MI, heart failure, hospitalizations, or deaths. So continuous outcomes give you more power. They had 47 patients who had PFA and about 25 who had RFA, and in the 47 who had PFA, about half had just PVI alone, and the other had PVI plus other ablation in the left atrium. The main finding was that compared to baseline, the RBC microparticle concentration increased 12-fold post-ablation and returned to baseline by 24 hours in the PFA group. At 24 hours after PFA, the concentration of LDH and indirect bilirubin increased, whereas haptoglobin decreased significantly, all statistically significant, and the authors concluded that PFA was associated with significant post-procedure hemolysis. Okay, my comments. The first thing to say is why this study was done. The authors did this study because a new complication of PFA has emerged, that is, the hemolysis of red blood cells from repeated shocks in the left atrium. Remember that a PFA delivery is a shock. The recent Manifest 17 study noted 5 patients had enough hemolysis after PFA to sustain acute kidney injury and dialysis. Now, we've been doing thermal ablation for 20 years and never seen enough hemolysis to have acute kidney injury. The theory behind hemolysis with PFA is that the high numbers of shocks in the left atrium actually shred red blood cells. Now, how this particular complication transpired is a classic story in medicine, a story of more is better. As the editorialists of this paper note, the first author is Dr. Pascal Fife, and I'm sorry for the American pronunciation. They noted that when PFA was approved, the manufacturer gave precise instructions about how many lesions to give. Now, I don't know if the manufacturer knew that excessive shocks caused hemolysis. I wonder if they did know. But anyways, cardiologists tend to color outside the lines. So here is what I think is likely happened. Once cardiologists learned that PFA did not damage non-cardiac tissue, they figured more ablation is better. They were off to the races. Now, thermal ablation with RF or cryoballoon has the limitation of for carpet bombing, namely that if you got crazy and did excessive ablation, especially on the back wall, posterior wall of the left atrium, you risk causing esophageal injury or phrenic nerve injury or any extracardiac injury. You basically can't go crazy with thermal ablation because you'll get into trouble. But with PFA, the idea was that you could blast away and not hurt non-cardiac structures. And in my opinion, there was another factor leading to more ablation in PFA cases, and that is Twitter or social media. EP Twitter overflows with these post-PFA three-dimensional maps of the left atrium that show tons of red areas. Now, red areas on a 3D map means you've ablated all the myocardial activity. And I will admit to being emotionally pulled by the post-ablation map showing you've ablated large swaths of atrial myocardium. It's compelling. You're like, I vanquished that, and obviously that will help AFib. The problem is, of course, A, we don't know if the AFib source was in the area that we made red or ablated. B, no trial is yet to show that ablation outside of a basic PVI improves outcomes, even in persistent AFib. And C, we don't know if the massive degree of obliteration causes harm in the future. Perhaps it causes a prothrombotic state. We don't know. Yet, EP docs are often resistant to evidence. See also here left atrial appendage occlusion. And now, one of the downsides of this scorched left atrial policy is shredding of RBCs. I think the main value of this modest paper from Prague is that it seems to confirm the theory that PFA does cause hemolysis by disrupting RBCs in the left atrium, and the more PFA you do, the more hemolysis you get. All right, another topic in AFib, and I'll move on from AFib in a minute, but let's talk about a self-serving surrogate marker called DAT, or get this, diagnosis to ablation time. Okay, the stated theory, paroxysmal AFib can sometimes progress to persistent AFib. And of course, persistent AFib is harder to ablate and control. So early ablation is obviously beneficial, right? Yet there may be another factor in the movement to ablate early. EP doctors like to do procedures. It is a hook that we hang much of our self-esteem on, doing procedures. Hospitals, industry, and doctors also make lots of money when we do procedures. Now, my field has therefore come up with a highly self-serving surrogate marker called diagnosis to ablation time. Shorter is good, longer is worse. Now, observational data has shown an association between longer diagnosis to ablation times and higher rates of AF recurrence after AF ablation, and proponents just say, well, if you wait longer, you're going to have more advanced AFib and it doesn't respond well to ablation. Now, geography becomes a factor in the diagnosis to ablation time as well. That is, in some countries with public health systems, the waiting list for AF ablation can be many months to a year or more, and that long of a time may indeed allow progression in some patients. However, in the U.S., I have witnessed cases where diagnosis to ablation time thinking or early ablation is misused to pressure patients with very low burden, early AF, to have ablation, where I think watchful waiting may have allowed AF to dissipate or be easily controlled with less invasive means like, say, weight loss or sleep apnea therapy or reduction of alcohol intake, or dare I say, take an antiarrhythmic for a few months or a year to suppress it. Now, the group of John Kalman and Peter Kistler in Melbourne has been interested in empirically studying the diagnosis to ablation time surrogate. Last year, they published a small RCT in the European Heart Journal, and I'll link to it, where 100 patients were randomized to either an early ablation strategy within 1 month or a delayed ablation strategy, which is optimized medical therapy and ablation at 12 months. And they found no significant difference on AF ablation outcomes, none. Well, recently, JACC-EP has published Wellwergen's group most recent study. This was an observational study, a sub-study from the CAPLA trial. CAPLA, remember, randomized patients with persistent AFib to PVI alone or PVI plus posterior wall isolation. And the main CAPLA trial found no benefit from posterior wall isolation. For this observational study within an RCT, they broke up the diagnosis to ablation time in the 334 patients in the CAPLA trial into quartiles based on time. So quartile 1 was your diagnosis to ablation time was in the first year. Quartile 2, 13 to 28 months. Quartile 3, 29 to 66 months. And quartile 4 was greater than 67 months. The main outcome measure of this observational study was AF recurrence after the ablation. So in quartile 1, 37% recurred, quartile 2, 45, quartile 3, 48, and quartile 4, 57%. They did a multivariable analysis, and the diagnosis to ablation time in quartile 4 was the only factor significantly associated with the risk of recurrence. That hazard was 1.60, but it was barely significant as the lower bound was confidence interval 1.005 to 2.5. So the p-value was 0.048. So barely a significant difference. However, the median AF burden measured in quartile 1 was 0% AF. The median AF burden in quartile 4 was only 0.33%. They also measured quality of life, and this improved markedly in all quartiles. There was no difference in quality of life measures. So the authors concluded that a shorter diagnosis to ablation time did have lower rates of AF recurrences, but the differences were modest, and all quartiles had very low AF burden and similar improvements in quality of life. So my comments on this. The strength of this observational study was that since it occurred during a rigorous RCT, there was good data collection, including implantable loop recorders. There's also little reason to think that there was selection bias, as the authors simply took the time of diagnosis to ablation time on all comers to the study, and it just seems like a random allocation of a diagnosis to ablation times. Of course, CAPLA was powered to assess PVI alone versus PVI plus posterior wall isolation in the 334 patients. And this study breaks the groups into 4 groups, so there is not going to be adequate power. So all of these findings are hypothesis generating. Yet I think the fact that the difference in AF recurrence is being modest, 37% versus 57%, and the observation that AF burden was extremely low in even the longest diagnosis to ablation group, longer than 5 years, argues against the DAT being an important surrogate. These modest differences are far less than has been reported in methodologically weaker observational studies. And I totally agree with the author's discussion in the paper that AF ablation can still result in very low AF burden and quality of life improvements in patients who have had AF off and on for up to 5 years. I also agree with their comments that there can be strong reasons to ablate AF early. For instance, in patients with severe symptoms and or heart failure, it is unwise to wait, and we should ablate. But the notion that all patients with the diagnosis of AF should have short diagnosis to ablation times is not supported by this work from Melbourne, this paper, and their previous small trial. Diagnosis to ablation time also ignores the important work from the loop authors, specifically my friend Søren Diederichsen, who has published that short duration AF often regresses or stops completely. I would also cite the work from the group in Groningen and Maastricht, which have shown that only 5% of patients with PAF progress to persistent AFib every year. I think that DAT is a dumb metric. It is self-serving, and it encourages overuse of AF ablation. The Melbourne work, as well as those who have shown how variable the natural history of AF can be, have empirically shown that the DAT should be abandoned. In its place, we could say something like, patients with AF are best served by having a good doctor, not just a good proceduralist who wants to ablate early. As the Melbourne authors argue, any time can be a good time to ablate AF. And I continue to believe that in many patients with AF, we need to give peace a chance. All right, final topic, future cardiac risk. This is a hot one. JAMA has stirred intense conversations this week regarding predicting future cardiac risk. The controversy stems from a new equation from American Heart Association called the PREVENT equation that they released last year. But first we have to go back a decade to around 2013 when the AHA and ACC recommended the pooled cohort equation, PCE, I often dazzle patients who ask about statin use in the EP clinic. They say, "Doc, now that we've controlled the palpitations, can I ask you about whether I should take a statin? My primary care doctor wants me to take it for my cholesterol." So I ask, did they go over your 10-year risk with the calculator? They almost always look confused. The answer is almost always no. He just said my cholesterol is high and I should take the pill. I then have them pull up the pulled cord equation on their phone, enter the data, and in 2 minutes, we have their 10-year risk of a non-fatal cardiac event. Then we multiply it times 0.25, 25% risk reduction, the estimated effect of a statin, and they can see their 10-year risk taking a pill every day, their 10-year risk without taking a pill. It truly shocks me how few patients have done this exercise with their primary care clinician. It's almost 0% in my experience. Now, the guidelines set out by the top people in cardiac prevention would recommend statin therapy for any patient when the 10-year risk calculates higher than 7.5%. And statins would reduce that risk to about 5.5%, thereabouts. Now, the USPSTF uses 10% as the risk threshold for taking statins. But my point is that the threshold is totally made up and arbitrary. We know that statins reduce risk at pretty much any risk threshold, and we also believe the time exposed to a low LDL may be quite important. So my view has evolved, and I think it's the patient's decision to take or not take statins. Patients sometimes are maximizers. Maximizers may take it at lower risk thresholds. Minimizers might not see the benefit of a few percent reduction over a decade. Well, the top people have come up with what they argue is a better calculator than the PCE. The PREVENT equation incorporates kidney numbers, the estimated GFR. It also does away with the race input, and it uses zip code. In general, PREVENT comes up with lower 10-year risks than the PCE. Now, many experts felt that the PCE overestimated risk, and PREVENT was developed using larger and more contemporary data sets. What's more, PREVENT had better calibration when used in contemporary populations. However, the PREVENT score has yet to make it into guidelines, and one reason may be the study published in JAMA this week, first author James Dio from Brigham. Now, the Brigham team, and along with many centers, set out to estimate the number of U.S. adults who have changes in their risk category, changes in their treatment eligibility or clinical outcomes when applying the PREVENT equation versus the PCE. Now, they used the NHANES population of nearly 7,800 U.S. adults from 2011 to 2020. Their main measures were the differences in 10-year risk, ACC and AHA risk categories, statin eligibility, and then projected occurrences of MI or stroke in the U.S. population at large. These were young patients, a median age of 53, half women, and they found 5 major things. First, the PREVENT equation would reclassify about half of U.S. adults to lower ACC and AHA risk categories. The PREVENT equation would classify very few patients, 0.4%, of U.S. adults to higher risk categories. Usage of PREVENT would decrease the numbers who reach statin eligibility, and this would affect 14 million people. They also looked at blood pressure treatment thresholds, and PREVENT reduces this by 2.6 million adults. Fourth, eligibility changes would affect twice as many men as women and a greater proportion of black adults than white adults. A study estimated that over 10 years, these decreases in treatment eligibility could result in 107,000 additional occurrences of myocardial infarction or stroke. Well, this is interesting, isn't it? On the one hand, the experts, the top people, say, compellingly so, that this is a more accurate equation. But on the other hand, it decreases the number of people who meet eligibility thresholds and therefore increases the number of cardiac events, at least probabilistically. Now, what do experts want? A better formula or more people on pills and fewer events? I'm asking. I'm not sure that even they know. I have to say that I enjoy seeing the experts grapple with the tension of this new equation. The problem with the expert opinion to use this risk-based approach to statin treatment or blood pressure treatment is that people have different ideas about risks and pill burden. Now, my view as a patient, so I'm old enough to be a patient. Now, whether my 10-year risk is 8% or 6% or 4% matters not to me. Why? Because I'm married to a palliative care doctor. This teaches me that heart disease is only one of the many terrible things that can happen to you. I mean, you can have trauma, cancer, infection. Cardiologists don't seem to think of these competing risks. 10 years brings a lot of competing risks. So, despite my training in medicine and science, it's hard for me to sort out a 4% versus 8% risk of a non-fatal event in 10 years. To me, it seems like no difference. And I also don't like taking pills. Now, one thing is for sure, though, what the expert thinks is my threshold to take a statin doesn't matter to me because it's made up. It's arbitrary. Now, you could have a different person in middle age. He or she might be a maximizer. Say everyone in this person's family had early death from MI. This person may want to do everything possible to reduce a cardiac event. So for maximizers, they don't care what the 10-year risk is, they just want it lower. So they could accept a statin at a much lower threshold. It doesn't matter what the experts think. If the prevent equation tells the maximizers they went from, say, 10% to 6.9% risk, they don't care. They want it lower. Now, a couple more comments. Dr. Venk Murthy, one of the authors of this paper, cardiologist from Michigan, on Twitter pointed out other issues with risk-based decisions. One is that it doesn't consider life years lost. That's important because, say, a 55-year-old has a fatal MI. Now, in the probabilistic counter, that counts as one event. But that's far worse than an 80-year-old who has a fatal MI. That 55-year-old may have a low risk per prevent, but one event is a massive issue. So one way of thinking is that young people get more potential benefit even though their calculated risk is lower. Another point Murthy made is that risk-benefit is driven by many different preferences and rare events. This makes me think about another tension from this study. Experts who worry about different thresholds worry about populations. That is, if prevent lowers the calculated risk and we keep the same statin threshold at 7.5%, then we'll see more MI events in the population. But this is not how clinicians think. We don't deal with populations. We deal only with patients. We should prefer the more accurate formula, in my opinion. Now, one side effect I hope comes of this tension is that more clinicians start discussing risk-based decisions with their patients rather than just saying, take this pill for your cholesterol. This is a contentious and kind of curious and fun topic because it makes you think, so I'm interested in what you think, and so let me know. And that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, please take the time to give us a rating on whatever podcast app you use. Write me a comment. These things go a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.